Vamos a comenzar en el día de hoy con este webinar en el marco del taller para investigación clínica que se está realizando en la ciudad de Cali. Para este primer webinar tenemos al doctor Enrique Soto, quien es oncólogo médico del Instituto Nacional de Cáncer de México. Y la presentación está titulada Retos y oportunidades en el manejo de la inmunoterapia en pacientes con edad avanzada. Entonces los dejo con el doctor Soto.
Muchas gracias, doctora, y muchas gracias por la invitación. Voy a dar la presentación en inglés porque tenemos miembros del grupo que son brasileños y también supongo que habrá de otros lugares del mundo conectados. So, my name is Enrique Soto. I'm a medical oncologist and a geriatric oncologist, and I work at the National Institute of Medical Science in Mexico City. That's my Twitter handle in case you want to follow me or ask me questions after the presentation. And today I'm going to talk about challenges and opportunities for the study of immunotherapy in older adults with cancer. I'm not going to talk about the mechanisms of immunotherapy or how they change in older adults, but rather about how we can study immunotherapy in other patients and how this is an opportunity to create new studies and an opportunity also for the developing world to develop studies in cancer and aging. So it's no secret that the world is getting older. This is a picture of the world from 2015. Countries in red are those with a larger population of older adults. And as you can see, most countries with an aging population 5 years ago were located in Northern America and in Western Europe. But if we fast forward to the future, to the year 2050, most of the world is now in red. So the world is going to get older, and most of this population aging is going to take place in developing regions of the world, mainly in China, India, and of course in South America. So although population aging is happening everywhere, it is happening mostly in developing regions of the world. And here I show you a graph of the world's population by every 5 years, from 2010 to 2035. And as you can see, this increase is going to happen everywhere, but it's mostly going to happen in places like Asia, Africa, etc., because those places, the baby boomers of those places were born later than the baby boomers in Europe and in Northern America. And even today, almost 400 million older adults are living in low and middle income countries. So even though the proportion of older adults in Europe and in the US is larger than in the developing world, the absolute number of older adults is much larger in low and middle income countries than in high income countries. Here I show you the projections of cancer in Latin America. This is taken from the GloboCan website. This is the projections for patients aged 0 to 64 years. As you can see, in the year 2020, there were about 732,000 cases of cancer in this population, and this will increase to about 939,000 cases by 2040. But if we look at the population aged 65 and older, the increase in that population will be enormous. So it will almost double from 735,000 cases to almost 1.5 million. So although older adults represent a small fraction of the population of Latin America, of about 10 to 15%, they take half of the cancer burden. So this is an example, an excellent example of a disease that is a disease of aging. So cancer, almost all types of cancer are much more common in older adults than in younger individuals. And sadly, outcomes in cancer care vary enormously by age. So this is the mortality to incidence ratio for all cancers combined for each region of the world and by age group for the year 2018. We published this in Journal of Geriatric Oncology in 2017. And as you can see, the incidence to mortality ratio is lower in more developed regions of the world, like Oceania, US and Canada. But if you look at developing regions like Africa, Asia, or Latin America, the incidence to mortality ratio is higher, and it gets higher as you age. So if an older adult age 75 years and older gets cancer in Asia, most likely she or he will end up dying of cancer. And this is in contrast with other regions of the world that have a far lower incidence to mortality ratio. So it is obvious that we need to improve the care of this population, and the way to do that is to include geriatric principles into the care of every older adult with cancer. And in order to do that, we need to improve the evidence base. And that is why you're here, because you are trying to build studies, and that is why people are watching, because we need to build studies that are meaningful. We talked about the research question today, and this is a problem worldwide. Older adults are not getting appropriate treatment for older age, and there is a need to build the evidence base. What about immunotherapy? That's why we're here. So we recently published this study in Archives of Medical Research, looking at the need for immunotherapy in Latin America. And we looked at GloboCan data and pulled together all the tumors for which patients are potential candidates to get immunotherapy. And there are about 500,000 people in Latin America who are potential candidates for immunotherapy. And of these, as I showed you before, approximately half or more will be older adults. So approximately 200 to 300,000 older adults in Latin America could be potential candidates for immunotherapy every year. And yet, we almost have no data about the use of immunotherapy in this population. So what are the gaps in knowledge in older adults? Older adults are vastly underrepresented in clinical trials of novel therapies. This has been true forever. So older adults are a very small proportion of trials of surgery, chemotherapy, radiation therapy, and now of immunotherapy. And this is mostly because of very restrictive inclusion criteria. There are even some trials nowadays that have upper age limits. Most trials do not have upper age limits anymore. And in fact, the NIH now has a policy that does not allow you to have upper age limits. We have limited knowledge regarding the efficacy and safety of immunotherapy in older patients. This is particularly true for octogenarians. So if you look at subgroup analysis of studies of immunotherapy in older adults with melanoma, kidney cancer, lung cancer, most older adults are aged between 65 and 75, and very few patients are over 75 in this trial. We don't know what the effect of immune senescence is on the effectiveness of these drugs, and this is something that we have to study further. We don't know what the role of frailty is. So are older adults who are frail, who have deficits or impairments in their everyday activities, more likely to have toxicity from immunotherapy, or less likely to have positive effects from immunotherapy? We don't know that. And the question that I want to answer today, or help to answer today, is how can we develop studies and develop protocols that tackle these very important questions for a large share of our population? And I want to refer you to this manuscript. I encourage you to read it. We published this earlier this year in Lancet Oncology. And these are the priorities for the global advancement of geriatric oncology, published by the International Society of Geriatric Oncology. And in this manuscript, we talk about how to improve education, how to improve clinical practice, how to improve policy making and international collaborations. And importantly, we talk about how to improve and what are the future strategies and future priorities for research in geriatric oncology. And I want to highlight 3 points. The first is increasing the relevance of studies for older adults. I'm going to discuss this a little bit further. Evaluate the benefits of allocating treatment based on geriatric variables. I'm going to show you some examples of how to do this. And finally, using personalized medicine technologies in older adults. This is a little bit beyond the scope of what we're discussing in this workshop, because we mostly spoke about big data, next generation sequencing, things like that. So how can we increase the relevance of clinical trials for older patients? Well, older adults, to begin with, should be included in clinical trials. Older patients want to be included in clinical trials, and it's usually physician bias what impedes them from entering, and ages, behaviors in the healthcare system, in the design of studies, and in physicians themselves. And inclusion criteria usually select only the fittest, stronger older individuals. So if you have seen the inclusion criteria for a clinical trial, you have to have perfect liver function, perfect creatinine, ECOG 0.1. So the older patients who end up getting into clinical trials are superhumans, and they do not represent the older individuals that we see every day in our waiting rooms. So we should broaden eligibility criteria. There are several initiatives for this, most notably the one by ASCO and Friends of Cancer Research, which was published in Journal of Clinical Oncology a couple of years ago, authored by Stu Lichtman. Create older adult-specific expansion cohorts. I'll talk a little bit more about that. And, of course, older adult-specific trials, although these are still, there are very few of these. And, importantly, and as we discussed this morning with Dr. Dumas, we have to ask the right question for the right patient. And for older adults specifically, perhaps we have to think about changing the outcomes that we are measuring in our clinical trials. So we traditionally have these oncological hard outcomes, and those are the things we oncologists care about. We care about response rate, we care about progression-free survival, we care about overall survival, but those are not necessarily the things that matter the most to patients. And other outcomes, such as quality of life, function, or a combination of response and patient satisfaction, patient-reported outcomes, may be as important or more important than survival for older adults. So the first thing we have to ask when we're designing a study is what matters to our patients. No? Is overall response rate, is a reduction of 10% in the volume of a tumor relevant for the patient in front of you? Perhaps not. So we did this. We asked patients living in the US at a single cancer center in California. We asked them about their preference. So we selected 240 older adults who had cancer, all types of cancer. A quarter of them had localized disease. They were before the start of treatment, and we asked them to prioritize certain outcomes using validated tools. So we gave them these tools and asked them, what's more important for you? And we gave them options: survival, keeping your independence, maintaining your cognition, etc. And among this population, not all of them were metastatic or had metastatic disease. About half chose living as long as possible, but 46% chose other outcomes over survival. So patients preferred maintaining their independence in everyday clinical activities than not living as long as they could. Or they preferred avoiding symptoms than prolonging their survival. And when we asked them about their cognition, 80% of patients said they would rather die than take a medication that would impair their thinking abilities. So the things that we value and that we included in our clinical trials may not be the same things that our patients value in their everyday life. And we have to keep this in mind when designing clinical trials, and mostly when we are designing it for populations of older individuals. So how can we include this into clinical trials? This, for me, is one of the best examples of how to do this. This is the overall treatment utility. This was designed in the United Kingdom, initially for a study called FOCUS-2, which is a study of various strategies for tailoring chemotherapy in older patients with colorectal cancer. And it has also been used in the GO2 study, which was published recently in JAMA Oncology. And what they did for this overall treatment utility was to do a composite endpoint of patient values and the patient's perception of treatment and the physician's perception of treatment. So patients who had a good treatment utility, their clinician said, this treatment is working for my patient. They have clinical response or radiological response. The patient was satisfied with treatment, so they asked the patient, was this treatment good for you? And the patient said, yes, I think this was a good treatment for me. They had no major toxicity, and they had no drop in quality of life. So when patients had this composite endpoint, they were considered to have good treatment utility. Intermediate treatment utility was when there was disagreement. So the physician said, this treatment is working. The patient is improving, the tumor is shrinking, but the patient said, I feel terrible with this medication. So even though patients may have a response or a prolonged overall survival or disease-free survival, they were not feeling very well. And poor treatment utility, both the clinician and the patient said that the treatment was not working. So this is a very nice way to incorporate patient preferences and the patient's perception of treatment into the outcomes of a clinical trial. And this is the GO2 trial. I think this is one of the nicest trials specifically designed for older adults. This is with conventional chemotherapy. And these were patients with gastric cancer, and they were randomized to 3 different levels of drug dosing. So 100% chemotherapy dosing, 80% chemotherapy dosing, or 60% chemotherapy dosing. And they looked at disease-free, overall survival, and overall treatment utility. And this is how they present the results of overall treatment utility, which I think is very nice. So these are the different types of patients with the different levels of chemotherapy dosing. And those patients in green have good overall treatment utility, so they like the treatment, the physician likes the treatment. And patients in red have poor overall treatment utility. And as you can see, this varies depending on the dose, also on age, and and particularly depending on the frailty of the patients. So patients who are frail do better with reduced dosing. They experience better overall treatment utility. And very interestingly, in this trial, reducing the dosing by 40% did not lead to an increase in mortality. So if you tailor your medications to your patient, if you tailor the drugs to your patient, you may have better patient-reported outcomes without affecting mortality. And this is an example of precision medicine without having to sequence any tumor. No? So just tailoring treatment to the right question and for the right patient. So how can we better describe this population? And this is the next point in the SIOC priorities. How can we better characterize an older individual in order to understand if he or she will tolerate treatment? I bet that all of you have had patients, older patients, 76, they look great, you give them chemo, they do terribly. And you have the exact same patient, very similar characteristics, you give them chemo and they do great. So how can we better understand patients going beyond what we usually do in oncology? And the answer to that is by doing a geriatric assessment. So the geriatric assessment has been around for decades. It was invented in the 1950s, but it has only recently been adopted in oncology. And in 2018, ASCO developed the first geriatric oncology guidelines, which include the recommendation to perform a geriatric assessment in every patient that's starting a new treatment. And SIOC recommends, and ASCO as well, including some form of geriatric assessments into all clinical trials and studies. What are the parts of a geriatric assessment? So it's not too sophisticated. An assessment of functional status by looking at the instrumental activities of daily living and the physical function of individuals. Looking at nutrition with something as simple as weight loss, although there are more sophisticated questionnaires. A psychological assessment of depression and anxiety. An assessment of cognition and decision-making capacity. A thorough assessment of comorbidities. This is actually one thing that oncologists, we do very well, assessing comorbidities. It's highly rated by oncologists, all oncologists do this. An assessment of falls, which are predictive of toxicity and of negative outcomes. An assessment of non-cancer specific life expectancy or non-cancer specific mortality. And finally, a calculation of treatment toxicity. And all of those things are what composes a geriatric assessment. So how can we use this for designing clinical trials and for tailoring treatment for patients? So I'm going to show you an example, which I think is the best example of using the geriatric assessment in the design of a clinical trial. This is the SOHIA trial, which used geriatric assessment for treatment allocation. This again is done with chemotherapy. Things like this have not been done with immunotherapy, but this is something that I believe should and could be done. So they did a geriatric assessment. If patients had no impairments in the geriatric assessment, they were considered as fit patients. If they had 1 or 2 impairments in the geriatric assessment, they were considered as vulnerable. And when they had more than 2 impairments in the geriatric assessment, they were considered as frail. And depending on that, patients were randomized to different treatment arms. So here I show you the allocation of the study. So they first did a randomization in which some patients were offered treatment based on their performance status, ECOG performance status and age, and another group had treatment allocated based on CGA or on the geriatric assessment. For the geriatric assessment arm, fit patients got doublet chemotherapy, vulnerable patients got single drug chemotherapy, and frail patients went straight to best supportive care without getting any type of chemotherapy. And in the other arm, based on performance status and age, patients that had a performance status of 0 or 1 got doublet chemotherapy, and patients with a performance status of 2 got docetaxel. So all patients in this arm had treatment. And there were no differences in survival, although many patients in the CGA arm did not even get treatment. So again, tailoring interventions based on frailty and on the geriatric assessment is a way in which you can actually select your treatments and select the right treatment for the right patient. So what about other trial designs. And this has come up today extensively. No? So not all evidence needs to come from randomized clinical trials. And there are other options when designing studies, particularly for specific populations like older adults. And Dr. Huria and our group published this manuscript in 2014. We published this in JCO. These are the ASCO recommendations for increasing the evidence base for treating older patients with cancer. And I'm going to show you some of the recommendations that were made and some examples, some published examples in older individuals. So the first is cohort studies. So in older individuals, cohort studies can be used to assess treatments that have already been approved. The cohort can be defined by the type of older individual, by the type of tumor, or by the type of treatment you're administering. This should be always, and as we discussed today in our workshop, hypothesis driven. So you do have to have a hypothesis of what's going on in your cohort. What are these cohort studies good for? So they can identify patterns of care. They can help you understand decision making, which is very important. How are physicians actually making decisions about treatment allocation in older individuals in everyday clinical practice? And they can also be useful for determining toxicity or for determining the feasibility of completing some treatments. So in some cases, you may start a treatment and end up not completing it. And so these cohort studies can be good for assessing the feasibility of administering full courses of treatment for older individuals. And of course, they have problems. There's a lack of randomization, and lots of data management is needed. This actually came up today in one of the workshops. When you're looking at cohort studies, you may have a ton of missing data. It may be very difficult to go and retrospectively collect everything that you need to collect. Here's an example of a cohort study, a simple cohort study in older individuals taking immunotherapy, published in JAMA Dermatology. And as you can see, this is not a large sample size. So these are about 100 individuals with melanoma who got immunotherapy, and they looked at progression-free survival by age, showing that there was no difference between older and younger individuals. And this is important because clinical trials, as I said, often do not include older individuals, and when they do, they include very fit older individuals. So looking at these real-world cohorts can help us better understand how patients we see in our clinic every day will tolerate treatment and how effective this treatment will be. Another trial design is conducted embedded studies. So here, the proposal is to include measures that may be interesting for geriatric oncology into larger clinical trials. So a colleague is designing a clinical trial of a new drug, testing a new immunotherapy drug in a population that's not selected for older individuals. And you can include in there a geriatric assessment for those age 65 and older, and that can help you use the GA to describe that specific cohort and use that geriatric assessment to describe the impact of therapy. The limitations of this study are that parent studies may not be older adult specific, and there may be representation issues because in some of these cases, entering into these embedded studies is optional. So some patients may opt in, and that may select for a fitter population, for instance. This is an example of an embedded study we did into KLGB 94003, which is a study conducted by Dr. Hyman Moss, was published originally in the New England Journal of Medicine, looking at different chemotherapy dosing and different chemotherapy treatments, monotherapy versus combined therapy in breast cancer in older individuals. And embedded think that's where the Uriatic assessment comes in. No? So the Uriatic assessment is a way in which we can assess the physiological, the biological, and the functional age of individuals. Of course, what is old? It's a very difficult question to answer because by law, you may become old at age 60, age 65, age 70, depending on where you live. But getting old is not like black and white. No, you're not young one day and then the next day you're old. It's a gray area in which the way in which you age is completely heterogeneous. And that's where these types of measures of physical activity, the geriatric assessment comes in to actually identify those older individuals who may be 80 years old according to their birth certificate, but physiologically and biologically they may be 10, 15 years older, and they should be treated like a younger individual. So I think that when we start to use those metrics to design clinical trials and to include patients in clinical trials, we will improve the participation of older individuals and stop using these measures that are too subjective, like ECO or age itself, or even some lab values, no? that bias the study against other individuals. And I think that there are very good initiatives in this way. I think that having the NIH require the inclusion of older adults is a great step. ASCO is also taking very important steps in improving the recruitment of older patients into clinical trials. And I think that we'll see this more and more and more as geriatric oncology becomes a priority in my opinion. It's here. It's here.
Thank you for that talk. I wanted to ask something I think that is for geriatrics, but probably also for other populations that are outside of the mainstream, either because of where they live, or because of their age, or because of their culture, or whatever. The inclusion of patient-reported outcomes, I think we are here in a group of future oncologists, it's coming. Fortunately, it's coming, but we're still very much focused on survival and surviving a year more in bad quality of life, etc. About the whole discussion. Could you explain which kind of patient-reported outcomes you focused on, and how did you decide which ones to focus on in your population? Because there are so many, and you cannot include them all, and which should be adapted because an elderly person will probably not, because they were all developed in younger, healthy populations, probably the same quality of life, questionnaires, etc., don't work the same way. How did you handle those?
So there are several ways in which that can be answered. So EURTC has a set of basic patient-reported outcomes and geriatric-specific outcomes that can be downloaded and utilized across trials. And there are another geriatric-specific calculator is called ELFI, which was recently validated by an Australian group and used in a clinical trial. And the other way is to use the geriatric assessment, which is partially a patient-reported outcome. No? So as long as you're assessing these domains, I think that it really doesn't matter what exact tool you use. It's mostly assessing the important domains. So if you assess the ability to be independent in everyday life, an assessment of cognition, an assessment of psychological status, you ask about falls, you ask about nutrition, which we know are things that are important for older adults' everyday life. Regardless of the tool you use, you may be able to see these changes. So I do think that ASCO guidelines and the URTC have a very good guidance about what are the outcomes that are most important for older individuals and which should be included in clinical cancer therapies.
And how far they are completely other important topics. Like, can I still be of importance to my tribe rather than can I walk? These kind of things. Are there tools that I'm asking maybe for the audience, people who are going to do research? How are there things adapted to such situations, etc.?
I I did not have this. I did not have that in this presentation, but that's something I love to talk about. And the example lives in Milan or in Barcelona, if they can walk 1 block, 2 blocks, 3 blocks, that makes sense. If you makes no sense because what even is a block? That kind of the setting is different. For example, what we did in Mexico, we noticed that some of the PROs and the self-reported questionnaires that we were using were impossible for patients to answer. They made no sense. You are asking patients if they can golf. I mean, you can golf here, but in other places of Latin America, most people don't golf. So what we've done is we have adapted the questionnaires, and we have found questionnaires that are appropriate for our settings. There are questionnaires measuring these things in most settings. So not the exact same one that they are using in the studies in the US, but there are questionnaires for cognition, for functional status, etc., for almost every setting worldwide. And you can use the one you have, as long as you measure what you're supposed to measure. Yeah, that's very interesting topic. I don't know if there are any questions online.
Nope.
For another question.